All right, so I have the pleasure of introducing Sarah Hooper, who is a professor of practice and associate dean at UC Law San Francisco. In this capacity, she directs the JD concentration in health law and policy, co-directs the UCSF UC Law Master of Science in Health Policy and Law degree, and serves as the policy director of the Medical Legal Partnership for Seniors Clinic. Sarah has dedicated her career to developing innovative medical legal collaborations that advance equity in healthcare. And she has a special interest in complex care, and in particular, the role of law and lawyers in improving systems of care for underserved older adults with complex medical and social needs. Her work encompasses clinical intervention, such as the Medical Legal Partnership for Seniors Clinic, research collaborations such as the Care Ecosystem Trial, and educational initiatives for providers and the public, such as the statewide Medical Legal Learning Collaborative of the Dementia Careware Initiative, the Optimizing Aging Collaborative, and Prepare. She recently developed and studied a tool to support legal and financial decision-making for older patients with cognitive impairment called Clarity. And you can find her work, which has been published in many medical, legal, and health policy journals. So please join me in recognizing Sarah Hooper, a longtime collaborator and a most cherished friend of our geriatrics division. It's so nice to see all of you and to be with so many real-time collaborators and friends. And I was trying to remember the last time I was at Jerry Grand Rounds, and it was, I think, 12 years ago when Bree Williams invited me to talk about this idea we had for a medical legal partnership for seniors. And wouldn't that be cool? And now here we are, like 12 years later, and together, all of us have built and sustained and are scaling a national model of medical legal collaboration for older adults. So yay to all of us for that. So it's really fun. And as you've heard, a lot of my work has been with all of you. And today, I think and hope that you're going to see a lot of the work that we have done together or we're doing together reflected in this focus on conservatorship. And I hadn't really conceptualized a lot of our work together as a conservatorship prevention initiative. But in putting kind of all these pieces together over many years, I've started to think of it that way. And for reasons we'll talk about in a little bit, it's also a framing that has got the most attention from health systems who we are trying to encourage to engage in age-friendly practices and policies and systems change. So I don't have any financial disclosures. And so what I'm going to do around this topic today, and I hope it will be conversational, I want to talk first about why we should think about conservatorship as an adverse outcome, both for patients and for systems. And I'm going to talk about a little bit of data that we have around that, but also just sort of a theoretical framing of like why it's a health justice issue. And to get to that, we're also going to talk about the systems drivers of conservatorship, because it's lots of different systems things that are culminating in what happens often in hospitals as a conservatorship case. And then I'm going to leave you, I think, with some good news about some tools and strategies that you're maybe already working on or that we're working on together, again, that maybe we haven't thought of as conservatorship prevention interventions, but in fact are a piece of this big puzzle. So as all of you have taught me, it's better to start with a case. So interprofessional communication is always better with a case. So we'll start with this case. We've used a version of this in other trainings that we've done, but I think it's really instructive. So Mrs. Chase is an 82-year-old woman. She's had multiple hospitalizations and ED visits in the past 6 months, primarily for UTI and dehydration. Her daughter Miriam, who is an older adult herself, is her primary caregiver. They are tenants in an apartment in low-income neighborhood. They have other family, but they're not terribly helpful in the day-to-day their day-to-day life or care of Mrs. Chase. And Miriam works an hourly job and has reported some significant caregiver burden. So her team engages her in some advanced care planning. Thank you for amplifying my voice. I really appreciate it. That's what good colleagues do. We amplify each other's voices. So the care team, of course, recognizes that some advanced care planning would be helpful here. They talk to Mrs. Chase about who she would like to make decisions for her, and they make a note in the chart that she is the emergency contact, right? Okay, we've got a decision maker. And then they talk to her about goals of care at end of life, like primarily, what she would want at the end of her life. And that's sort of the nature of the advanced care planning that we engage in. So a few months later, unfortunately, police find Mrs. Chase wandering in her bathrobe and take her to the hospital. And at the hospital, she is assessed and given a dementia diagnosis for the first time. And the discharge team feels that she doesn't need to be in the hospital, but she does need more support. And so they recommend that she go to assisted living. And they find a facility that they think would be a good fit for her, but the facility refuses to take her. People are nodding heads. Why do they refuse to take her? No POA, right? And so the discharge team advises Miriam that she needs to file for probate conservatorship. And Miriam, already overwhelmed, already someone without a lot of access to lawyers or court systems or any of these processes, is like, no, I don't know what this is. I'm already caring for my mom. I don't understand why I need this process. I'm busy. I can't afford a lawyer. Barriers, right? And she starts to kind of disengage from the discharge team, which gets really frustrated with her, and starts to see her as non-compliant and starts to see her as maybe not having her mother's best interests at heart, right? I'm not describing any cases here. We're talking about national phenomenon, right? National phenomenon. Okay. So in a best case scenario, as many of you know, even if Miriam were well-resourced and were on the ball, so to speak, with conservatorship, that process could take 6 months to a year. And in the meantime, Miriam is in the hospital waiting for discharge. Okay. We've got a sophisticated group here, but in case we don't have any Britney Spears fans amongst us, conservatorship, aka guardianship, if you trained in other states, is a court process to appoint a person to make decisions for another person who is no longer able to decide for themselves. It is a dramatic civil legal intervention. It is one of our most dramatic civil legal interventions outside of our criminal justice system, because it removes civil rights, right? Our right to make decisions about our own bodies and our own lives. And so it's treated as a last resort for that reason. And the courts look at these cases and they say, I want to know what else we tried before we got here, right? And advanced planning is one of those primary alternatives. Like, could she still name someone? We have many forms of conservatorship in California. I think LPS and our mental health conservatorship system has been under the most scrutiny recently, but probate is actually the most common pathway for people with dementia, that we're starting to see kind of like co-occurring people with dementia and other mental illness that may make them candidates for the LPS system. But generally, I'm gonna mostly talk about probate today. And something that I've learned to start talking about with healthcare teams all over the country and the state is that we need to be clear about what conservatorship is and what it isn't as an intervention. So conservatorship is a decision-making intervention, right? It's a court transferring one person's decision-making right to another person to make different decisions than they're making, right? What it is not is a resource intervention, right? So if Miriam gets the right to make decisions for her mother, the court is not also giving her expanded Medicaid eligibility for long-term care supports and services. The judge is not magically creating beds or housing in the community that doesn't exist, right? And is not adding income or other resources that could maybe address some of the underlying reasons that they are struggling and that we think conservatorship is needed in the first place. So I just want to make sure we're starting with a baseline of what the intervention is and isn't, because I've actually found, again, not everyone is on the same page about what it is. And that's been one driver of conservatorship that I have seen. Okay, so who is conserved? Wouldn't we like to know? Wouldn't this be great to have? So the Britney Spears case, I think, highlighted something that a lot of people had been talking about for many, many years, but I don't think the public had been aware of, which is that we actually have very little data about the conservatorship system or who is referred into that system. What we have, there's a few data points that I think are helpful and point to some themes that I'm going to talk about and why this is, I think, a health justice issue. So Jennifer Moy has done incredible work out in Massachusetts around conservatorship and did a VA chart review in Massachusetts and found that it was dementia. So 56% of the people in hospitals who were referred for guardianship had dementia, which I don't know. I think we tend to think of conservatorship as an intervention around mental health, and it is, but possibly more in dementia than we've really been focused on, right? So that's instructive. The other thing that I think was really interesting is that I think a lot of people think of conservatorship as a no caregiver problem, but in fact, she found that 57% of the people in their system who were referred for guardianship had a family guardian. And so it was a stressed caregiver, a family conflict. There was something else going on there that was responsible for this referral. And I think in our work with Track Team, we found that that was true too at the VA, that we were surprised at the number of cases for which there was someone who could be appointed, but for various reasons, they were unavailable or it was really hard to work with them. Okay, and so her study didn't have any data about SES, and of course it's the VA, so what she found is that, overwhelmingly the folks who were referred for conservatorship were white and male. Okay, not that surprising. In non-VA settings in Florida and New York City, where we had larger data sets, we have actually found that conservatorship is disproportionately applied to older women of lower SES, right? So more marginalized communities and people with disabilities, but I kind of discount that because that's sort of the definition of why you're seeking conservatorship in most cases, right? So we have reason to think that the way that we often think about conservatorship is maybe not consistent with how it's actually playing out. We do need more data, I will say that. What we know about the health system impacts of conservatorship are that it's a significant contributor to extended length of stay nationally. I think lots of people think, oh, it's just a Laker hospital, but this is a national phenomenon. And in Massachusetts, they did a statewide all hospital study and found that it accounted for between $18 and $25 million in bed stays annually. And work that we've done at the VA and that colleagues have done at Duke, we've estimated that the preventable cost of conservatorship is somewhere around $800 to $1.2 million per year per hospital. So it's a significant impact in terms of financial impact to hospitals. And of course, the most important thing to all of us, right, is that extended length of stay risks poor health outcomes to patients. And in work that Kenny Lamb in our group and others have done, we've documented that it also contributes to significant moral distress. So this is, for you fellow health policy geeks, a quintuple aim issue, right? We're talking quality, we're talking cost, we're talking workforce. And I think in some of the data and in our anecdotal experience, I think that this is a health equity issue, right? Because a health equity, a health justice issue is one that disproportionately impacts marginalized communities and is avoidable and preventable, right? And there are tools to prevent this, and we'll talk more about that. But I do want to linger just for a minute because I think there's a healthy debate about conservatorship as a beneficent needed intervention. And I am not one of those people that's going to stand up here and tell you that conservatorship is never needed. You will find those people. I'm not one of those people. However, I do think, particularly in health systems, we need to be very clear and have some focus on the impacts of this intervention to patients and to their families. And when you think about the fact that it is, maybe lifetime discrimination, lifetime social risk factors, compounding with health factors that are bringing people at risk of conservatorship, and then they reach the end of their life and we're going to take their civil rights away, and that's our best intervention for helping them at this stage of their life, that can't be the case, right? That just can't be the case. We can't do this. And it's also important to think about, and others have documented this, that, Black and brown populations often do not experience involuntary mental health interventions as beneficent, right? But are experienced as an extension of the carceral state. So we have to think about the ways in which the interventions that we think are good for patients are not experienced that way necessarily, and that different communities will particularly feel the impact of that because of a history and legacy of structural racism and discrimination. So be very thoughtful about that. And then when you think about what I said earlier, that we don't know actually that conservatorship will get us resources for this person, right? Or that the long-term outcomes will be beneficial for them. What? We're going to have this dramatic civil legal intervention and we don't actually know if it's going to benefit them. That's wild. That's wild, right? So, okay. So I think we're all starting to see and think about, does this make sense as our primary response? And what I will say is that I have seen, I've seen, and others have written about, they see this data, right? And the response is, we need to speed up conservatorship. And that has been an ongoing conversation in this state as well. And so my sort of angst about this issue is in part response to that, right? Are we asking the right questions, right? Okay, so I want to talk a little bit more about the systems drivers of conservatorship. So how do we get here? What are the bigger things that are affecting people who are at risk for conservatorship? And I'm going to try and relate it to the case. So I'm going to talk about 4. So healthcare, fragmentation and cost, the social care, also fragmentation, but also underfunding, economic inequality, and then structural racism and other social inequality. Okay, so the way that we finance and deliver healthcare in the US is uniquely complicated. And that fragmentation is part of the problem and part of the driver of the need for conservatorship, because people like Miriam and Mrs. Chase have a hard time navigating these systems, right? But I can give you a real specific way in which fragmentation contributed to this conservatorship problem, right? So her team did some ACP with her, right? A major alternative to conservatorship is having people engage and name their own decision makers. The healthcare team did that, right? They put a note in the chart. But as you already know, because you're on top of all of this, the note in the chart of an emergency contact doesn't transition across settings. And we know that older people and people with dementia have a lot of care transitions, right? And that note in the chart, while perfectly fine advanced care planning, doesn't address this specific issue, right? Only a power of attorney does that and will empower Miriam to help her mother across all of those settings, right? Additionally, the way that we engage in advanced care planning is often about end of life, right? And POLST is well accepted. It's an important tool. It does transition across settings, but it's not a POA, right? And it also doesn't address something that matters a lot to Miriam and her mom right now, which is, where is she going to live, right? That's a huge part of decision making, and one that I don't know that we spend enough time with families around. So Miriam needed that authority. She also needed financial authority, because healthcare fragmentation and cost, right? Medical decisions are financial decisions. So she needed the tools, and she needed to understand her role in using them. But and I think this is a collective, we all collectively, health, social services, legal services, often don't meet them where they are with these needs. And here's a big gap, right? The older adults with greatest need for legal help don't get it. So the folks that we know, like people with dementia, who we know are going to need this planning, are not connected or don't access the services they need in the community, which is what brings me to this one. So our social care is disconnected and underfunded. So the US is an outlier, as you all know, in our per capita healthcare spending, but we're also an outlier in our social care spending. And you can see that in conservatorship cases, right? So the social stay cases, we're spending $2,200, $2,500 a day on a hospital bed, right? But could we have spent that money elsewhere in the social care services, which are actually driving the need for that health care cost? This is not my idea, right? This is something that's in health policy ether and has been in the health policy ether for a while now, and we're starting to respond to it, right? So like CalAIM is a reason that we are, is one of the ways in which we're trying to structurally respond to social care disconnection and underfunding in the health system. But I do want to point out that we have a frayed social safety net, but we do have services, right? And like legal services, for instance, are part of the aging network, are required to be part of the aging network under Title IIIB of the Older Americans Act. And so it truly kills me when I see these cases where you're like, well, could we just have met them a year ago, 2 years ago, 3 years ago? Would this be a different ending? Would this be a different story? How is it that we do have services in the community, frayed and fragmented as they are, but the people that they're designed for are not meeting them, right? So like, could the things that we have, and we're lucky in San Francisco, we have a lot of these that could have helped Miriam with her caregiver burden, with their income, with her understanding her, rights to paid leave, her rights in the workplace. Could she have accessed some of those things, respite and legal services? And why didn't we catch her earlier, right? Another major trend that drives a lot of caregiver burden and patient burden and is not just healthcare costs, but just economic inequality more generally. And the ways in which in the last 30 years, we've really transferred the responsibility for retirement planning from bigger institutions like employers to individuals, right? So I did this at Stanford last week and like nobody raised their hand, but do we all have pensions here? Do you all have a pension? Okay, so more than most. I did this at Stanford and like nobody raised their hand. So that's a big public policy shift, right? Like we've transitioned the responsibility for retirement from institutions to individuals to invest and manage resources to support their retirement. And that really results in a lot of economic vulnerability. Not to mention, if you don't have the kind of job that offers a 401k, you don't even have the opportunity to build that wealth, to build a retirement. So we see these numbers are just out as of last week. 14% of older adults in the US live in poverty, which is the highest proportion of any age group, actually. We see 1 in 4 Black, Hispanic, and AIN older adults in poverty, and we see an increasing proportion of older adults working for longer. So 19% working, and I think the projections I think that's about twice what it was in the 80s, and it's projected to continue growing. And that's an eye-popping number, 49% with no retirement account. So you think about what it takes to pay for healthcare, what it takes to pay for social services in this country, and then you layer on kind of a lifetime disadvantage. We shouldn't be surprised that people are coming to our hospitals with these needs, right? Because they're the sort of place of last resort. And really nobody can afford long-term care, right? Like nobody can afford long-term care. So even for the middle class, even for higher income folks, this need to be able to pay for services and navigate these systems is really a challenge and really an acute challenge for people like Miriam and Mrs. Chase. And not I mean, I think the other challenge that we've encountered, many of us, is that a lot of folks don't understand the spectrum of long-term care. So folks kind of think it's home or a SNF, and they don't really understand the options in between. So just kind of some basic literacy around that is really critical. Okay, so we know that there are relationships between socioeconomic status and race because of historical structural discrimination, but we also know from the public health equity literature that even when we control for social SES, that we still see in many areas of health disparities in outcomes by race, right? And so we have to think about how that might be playing into the kinds of people who seem to be showing up in our conservatorship rosters, right? And a way that this, I want to propose to you, could be happening in dementia is the fact that while we know older and Hispanic Americans are more likely to acquire dementias, they're less likely to receive a timely diagnosis, right? And report discrimination and care for a loved one. And what's the effect of that with planning? If you don't know, you can't plan, or if you don't know soon enough, you can't plan ahead. And when you think about all of these systems barriers, right, you've got the economic burden, you've got social care fragmentation, healthcare fragmentation. The people who are going to struggle the most in those systems need more time to learn how to cope with them, but they seem to be getting less time, right? And so the importance of early detection and planning is really critical. And so I have to say, like, when I hear these conversations in the policy space about conservatorship and, you know, we've got this failure to thrive and like social strain and this person has incapacity, I'm like, who has the capacity to thrive in these systems, right? We have structural incapacity. The question is not, I think we're asking the wrong questions. The question isn't, why didn't Miriam and her mother plan better? The question is, why didn't we help them sooner? And I think that's a collective, we as professionals who care a lot, and I know you care deeply about our patient clients, that particularly in dementia, these are the trains we can see coming, right? And so if we have 51% by that one estimate of our patients with dementia getting referred for conservatorship, that's on us. Right? Shouldn't it be? So, okay, I've bummed you out. It's a lot of bad news, but I'm actually quite optimistic. And here's why, because I think a lot of the stuff that we can do to prevent the need for conservatorship is stuff a lot of us are already doing and talking about. We just haven't put all the pieces together and we haven't thought about them as conservatorship prevention strategies. And we also haven't named it as a conservatorship prevention strategy. And I think that could be really helpful. So in a lot of our work together, I think we've kind of collectively, and I've identified 4 things on the outpatient side that we need to be doing. So we already talked about one, early detection, right? Because if it's detected early and we can then wrap services and supports around patients and caregivers, they have more time. They have more time to plan. They have more time to figure out how to navigate these systems and access the services that are hard to get. There are waiting lists, yes, for legal services because we don't have enough capacity. And so give us more time to help them is the other thing. So early detection is really critical. Durable powers of attorney, we've talked about that. I'm going to say more about that in a little bit, but it needs to include financial ACP as standard of care. And social needs screening and referral, right? So this is a trend. This is a health policy trend that's been emerging for like the last 10 years. There's incentives at CMS. We're seeing it in CalAIM. We're seeing it in the guide model. It's awesome. That's amazing. We should be doing this. The tools are not well optimized for older adults, but we can fix that, right? We can just slot in a couple of questions. But like decision-making and powers of attorney are not in those tools, but that's okay. We can help them adapt them. We can help them integrate them. But when we do the social needs screening and referral, we can help defragment that care, that connection with social care. And then caregiver education and support, right? Conservatorship, as I said, is not a no family issue. It is a strained family issue. And I think we need to understand why families are strained, right? It's not necessarily, though sometimes they are, uncooperative. It's that navigating these systems will challenge anybody's sanity, truly. So how can we intervene earlier and support them? On the hospital side, as many of us have found, we need our hospital teams to be supported with geriatricians, right? They need help. We're not that good at doing capacity assessments, particularly around issues like conservatorship, because it makes people feel squirrely and weird. But we also, I think, in the track team have found a lot of success integrating legal expertise as well from a patient community perspective. Is this really a capacity issue, or is this a resource issue? Like, are they actually declining services, or is it that they're just really hard to get? Have we done medication management? Do they need to be on all these? What time of day did we talk to them? All the stuff that you guys have taught me. I'm now a little dangerous and I ask those questions, right? Have we actually, like, what have we done to optimize capacity of this patient, right? Is the question we should be asking before we conclude that they need conservatorship. Because once we mark a patient in a hospital as lacking capacity or needing conservatorship, lots of stuff stops, right? And it's like a red mark that follows them across settings of care and can be very hard to undo. Really hard to undo, including getting them into other settings of care like assisted living and SNFs. I know all of you have encountered like a lot of this stuff. Okay, so we need to help hospital teams build capacity around capacity assessments. What a terrible sentence. I'm sorry. We also need to help develop systematic workflows for alternatives to conservatorship and make sure that there is a standard of care. And as I've talked to folks all around the state, there's often like no workflow and not a lot of understanding of alternatives. And that is something we can and should standardize. So that, you know, again, I'm not a never conserve person, but we should make real sure that we tried all the other things first. And finally, data. I mean, we don't know actually a lot in this state about who is being referred for conservatorship, and that limits our ability to intervene, right? So we should be able to characterize these populations, and then we should be able to target resources to them, right? So, you know, maybe, for instance, how should I say this? Intensive interventions like medical-legal partnership don't need to be targeted to all patients, but are we targeting them to the highest need patients, highest risk patients? I think we are, but I think we could probably do better, right? I think we could do more. And then anything on the outpatient list is stuff that's not optimal for hospital settings, but we know that hospitals may be most people's first line of access to healthcare or social services. And so we should be prepared in hospitals to do these things too. So, you know, like I said, stuff we're all working on already. This is good. We can do this. So shout out to our DCA team for the last couple of years in this Dementia Care Aware project that I'm sure many of you know, led by Anna Chodos and Josette. We have been running a DCA medical legal partnership network that is a statewide network of about 16 organizations, including legal aid organizations. And we developed a medical legal curriculum on 11 training topics that we thought would be helpful for people serving low-income older adults, particularly those with dementia, to address those needs, to address that socioeconomic insecurity, to address the planning needs, and to address the caregiver burden, right? So what should Miriam know about paid family leave? Or at the very least, where would we send her to get help with that issue, right? Like to help her manage her time and her care for her mother. And then a version of this talk I've been giving up and down the state to different teams around running the need for conservatorship. So we've developed a lot of training materials. You would be welcome to use them. The goal is to disseminate this knowledge and these tools as far as possible. We also developed training materials on YouTube. So we have a series of short videos on all of these topics that support providers in addressing kind of comprehensively the planning and social needs of these older adults. All of you know Prepare for Your Care by now. So I've been working with Rebecca on this, I think since 2009. We're her legal research team. This is a legal, I know, I did the research. This is a legally valid, durable power of attorney for healthcare in California and in most states. It's part one, right? So can we encourage people to do part one after we detect cognitive impairment in a low-income older adult? maybe not part two, maybe part one at least. And then I think financial advanced care planning should be standard of care in dementia. So we've developed a tool to support that as well. So for the last couple of years, really inspired by, I think, everything we've learned in Prepare over 12 years or so, I started thinking we need a tool like that for financial and legal planning in dementia. And what do you know? NIA opened up a funding mechanism a couple of years ago. We got the grant and we developed a tool, and we used a Delphi method to co-develop the tool with health professionals. Some of you know them, legal professionals from around the country, caregivers, and people identifying as having memory difficulties. And they helped us through a process of consensus figure out like what the content of it should be and what the features of it should be. And we published on this a couple months ago, and we have a user study that we're hoping to publish in a couple of months. But the idea here is that in health systems, if we do the early detection, if we do some comprehensive screening, even if you don't do screening, right? ADL, there's financial management in the IADL assessment, right? Like you're already doing this. So could you then just ask a question? Have you ever, what would happen if you needed someone to pay a bill for you? Have you ever named someone who could pay a bill for you? And then send them the link to this tool, right? So the clarity content that we developed is around naming financial and legal caregivers, and including for people with who rely on just public benefits. And then planning for future care. So what is the spectrum of long-term care and who pays for it and who doesn't? Getting legal help, talking with others, resources, and other things. So another thing is, so like Prepare, one of the important things around financial and legal planning is good conversations. So one of the things that we're trying to help promote through Clarity is how do you actually support patients and caregivers in having meaningful conversations about what this role requires, right? So we don't have caregivers who are in the hospital like, what is long-term care? What? Like I'm the person now. How can we improve communication around these issues, improve skills and self-efficacy? So we're modeling that. The tool does not complete financial and legal planning, and that is intentional. That is because of the risk of elder exploitation. And most, I think all legal aid organizations, if you try to find a form on their website, it won't be there. And that's by design, because just like we talk about in medical ACP, a lot of what's important is not just the form, like the form is necessary, but it's not sufficient. The conversations around the form are really important for us to assess if they have capacity to complete it, right? For us to assess who their social network is and assess the risk of financial abuse, right? We don't want to help someone fill out forms if we think that someone's going to abuse them. So lots of reasons why we don't actually help people. And also, anyway, yes, we are not legal Zoom. So that's not what we're trying to encourage here, but what we're trying to encourage is education and preparation for financial and legal planning. But we do have some worksheets, right? So some worksheets around planning to pay for long-term care, understanding those costs, stories, right, that present common scenarios, like the hospitalization one. Bob fell and is hospitalized and is going to need a lot of care that Medicare isn't going to pay for. Have you ever thought about who would pay your bill for you if you were in this situation? Giving people prompts and then asking them to respond to those prompts. And again, the idea here is that they are thinking through this so that when they do meet with legal aid or an attorney that they may be able to afford to pay for, they're having good conversations, right? And we're also, through some of our communications skills, for people who have never been to an attorney before, trying to demystify. So we actually show what a meeting with an attorney would look like, and we give them questions they can ask and provide information specifically about what legal services for older adults and people with disabilities are and should look like, so they know what to look for. So action steps, we've got some worksheets, and then it's available in English and Spanish. We're hoping to roll out to other languages. And again, like similar to our work in with Rebecca and Prepare, we want plain language to the extent possible with easily understood interface, and lots of repeated information across different pages, while kind of trying to minimize distraction and have other design features for people with cognitive impairment. And then we have referrals and linkages. And a big challenge with older adults is not that you can't find a lot of information about financial and legal planning on Google. The problem is you can find a lot of it, and a lot of it's bad. A lot of it's kind of scammy, right? So what we really want to do, particularly for low-income older adults, is really connect them to the aging network, right, as a front line. Connect them to those trusted services and free services, and then limit the number of referrals because they're really burdened. They don't really know how to assess a huge list of different kinds of services, right? And so for each state, this is a 50-state tool, we're saying, here are the tools, here are the programs in your community that are the most important and the ones intended for low-income older adults. So those referrals and linkages are in there. Okay, so we've got some tools to support and integrate with health-related social needs screening, with caregiver education and support. And we hope that these are tools that providers will be able to use to make that an easier task, because we understand you're not experts in financial and legal planning. Although some of you, I don't know, Catherine is really coming for her JD, I think, really making that happen. Okay, so then of course we know that some people will give them these tools and they're going to struggle to do them on their own. They really need help with somebody else. And then we know that some people just need that hot referral, the direct, immediate integration of social care. And so again, this is kind of consistent with a more national trend. Healthcare systems are experimenting not just with the medical legal partnership model, but with integrating a whole range of other social care services. And guys, we were doing it before it was cool. We were doing it before it was cool, right? So we've had this model since 2012. We're in all of these settings of care at this point. And we've really learned a lot, right? And so you all know Yvonne and Sarah and a lot of, and Elizabeth and our staff attorneys and our students. It's really a mobile model. As a lot of you know, we will go to patient homes. We will go to the setting of care that's easiest for them. And our target population, so in our last round of data, 67% of MLPS patient clients were socially isolated. 60% were at risk of institutionalization, 45% were from communities of color, 59% were at or below 200% of poverty, and LGBTQI and LEP populations as well. So I think in this model, we're doing a pretty good job of targeting high risk of older adults who are at real high risk of conservatorship. But it would be interesting to see if we are, right? Are we really meeting those folks where we need to be meeting them, and could we be doing that better? So I invite us to continue on that journey together. And I'll leave you with some broader kind of advocacy strategies around preventing the need for conservatorship. So one is we have this opportunity to scale the medical legal partnership model nationally. There's a bill in the House right now that would give states funding to scale medical legal partnerships for older adults. And of course, we, as the leading MLP for seniors, have a lot of thoughts about how that would be implemented, and of course, would love funding to go to the states. I think there's a lot of tools in CalAIM that could really address this problem, but we haven't named a conservatorship prevention strategy in CalAIM as an aim. And I also think older adults are not as visible as they could be in CalAIM programs. So a lot of us are kind of advocating around that. As I said earlier, I think health-related social needs screening tools will be hugely helpful in helping us identify social vulnerability in these populations. They're missing the decision-making piece. All of them are. So we need to screen for that and advocate and just modify. And then finally, voting. We're in a particularly contested and important year. all of these systems that are the root causes of these issues that we're talking about are just the products of human choice. They're just all the products of human choice, right? And the way that we more dramatically shape these systems is by engaging civically. And your voices matter a lot, like really matter a lot. And so please vote up and down ballot for people who are serious about health justice and really truly addressing health outcomes, not just the conservatorship issue, but all of these complicated issues that are driving us to conservatorship as an outcome. Okay, so I'm going to stop there and invite your discussion on this topic.
We're so lucky to have our UC Law colleagues as part of our interprofessional team, for our older people. So in our appreciation, we have actually, we have
so sweet.
It's a crystal plaque that says a teacher affects eternity.
Oh,
so
that's
our knowledge and eternity.
It's kind of amazing. Thank you.
So anyway,
that's
thank you.
Really good.
Absolutely.
Thank you.
And
really
maybe I'll start off the questions and then throw it open to the group. I know as a primary care doc at the VA, one of the things I struggle with is a lot of my patients, even when they do not have cognitive impairment or early cognitive impairment and could name a durable power, they are so isolated that they tell me they have no one that they could possibly put in. Like we have these conversations over, and I feel like I can see that train down the road.
Yeah.
Any thoughts on that? Because I've even gone to the social work where they've done these. They try to find family member, and that has not really any help. But I don't have any thoughts on that.
Totally. The unrepresented problem is still a huge problem. My first response is, and I know you, I know all of you, and I know that you often go above and beyond what other healthcare providers do to make sure that someone is truly unrepresented. If I'm talking to a statewide or national audience, I will spend more time there because I don't think that we are as thorough about that as we could be. I'll steal a line from Josette in one of our working meetings. We really could do more systematically to help patients think, what did you say? Broaden the net, widen the net. So you don't have to have a spouse. You don't have to have kids. You don't have to have a traditional family structure. There are people that you could choose as long as you trust them and they're trustworthy.
It's that trust part. I have patients that just, and if anything, they're saying, why can't you be my, and that's one thing the doctors can't be, right? So that's, they don't trust other people.
Yeah, absolutely. Well, so a couple things. One is we can still engage them around goals of care. We can still engage them in understanding the systems that are going to pay for their care. And then we do have rep payee programs, VA fiduciary, unfortunately, so we can advance designate rep payees. Unfortunately, we can't advance designate VA fiduciaries. And so we need to wait until someone has lost capacity to get a VA fiduciary. Rep payee can manage Social Security benefits, but nothing else. VA fiduciary can manage VA benefits, nothing else. And then this is a real need that you've hit on. We do, so it could be, we have some pro bono fiduciaries who serve as professionals that if you had more money, you could just pay them to do a lot of this for you. But of course, low income older adults don't do that. And often our rep payee services are strained. And so we do need more pro bono fiduciaries that could have a more limited role that an older adult could choose, right? Again, time, like if we had more time, is there someone that we could encourage them to meet and get comfortable with? I don't know if that's a model. They've been trying it in Montana. We'll see how that works. But the idea that a patient could choose someone on their own should always be our front line and just helping them along the way. And for some people, there won't be someone. That's it. Yeah.
And it sounds like I could refer them to the medical legal partnership too.
Yes.
Yes. Thank you.
Yeah.
Other questions?
We have someone Zoom as well. Let's see here. Can you still over there?
I can see. I'll read a couple that are from Zoom. It says, can we direct patients to view the Clarity handouts on a website now?
Yes. Planforclarity.org is the tool. Okay, put it in.
And Daniel Pan also asked, it takes a lot of time and effort to try to get all our patients to create a DPOA for healthcare. I cannot imagine how much time and resources it will take to help all our patients create a DPOA for finance. But I see how important it is.
Yes, hi Daniel. So no, you do not need to ask your patients. You don't need to engage with your patients in financial and legal planning. Please don't. When I say I think financial ACP should be standard of care, what I mean is, can we identify it as a need systematically that we know is an issue, particularly in dementia care, that we need to raise for people as something that they're going to need to address. And the sooner we do that and connect them to resources, the better, right? So I'm sorry, I didn't mean to suggest that we needed you to actually engage in financial ACP. That's our job in the legal community. We can do that. And we should do that. Please don't engage in unauthorized practice of law. But you are the person who, for a lot of these patients, will be the first one to see the signs that they are losing capacity. And right, financial capacity is one of the first to go. So the sooner we have that information, patients have that information, caregivers have that information, and know that legal services can help them prepare. That's what we're asking, just for the linkage, screening and linkage. Yeah.
Thank you.
Yeah.
Where do you ask your folks to place these documents? Like the hard copy.
So you also don't need to, wouldn't recommend that you get the financial POA. But what would be helpful is to document that they have it. And so that's where a document in the chart would be helpful, that they have it, but you don't need the actual form. Unlike a healthcare power of attorney, I don't recommend that you keep financial planning forms in the EHR, but it would be helpful when assisted living or other settings are pushing back, saying this person doesn't have authority. You can be like, yeah, they do. I know, because we help them with this, right? Yeah.
Sarah, can you say more about that? Because I think that comes up for us occasionally where someone tells us they are the durable power of attorney for finances, and we have no way to know if that's accurate.
Yeah. I think that it is okay. So I think that's okay. I don't know that you need to validate it if they know what that is, and that's their, well, I'll say a couple things. One is, people often confuse a durable power of attorney for healthcare with a durable power of attorney for finances. So I think a quick bit of education just to make sure they understand what they're talking about would be really helpful. But I don't think you need to independently verify that they have a power of attorney for finances. I think the healthcare part would be very helpful though.
Let me clarify.
Yeah.
The individual doesn't know whether they have it, but the person who says they are the durable power of attorney for finances say they are the person.
Yeah, that's okay.
So what if you're like writing a letter to a bank, like that they're going to take to the bank saying that they don't?
You're asking about capacity. Oh, do we have some tools for you? So if someone, that's a different question. Winston, we're getting into it. We need to get into it. So if someone asks you to complete a capacity assessment for purposes of a power of attorney for finances, then you should ask to see the form. Because not all forms require physician assessment, but some do to be valid, and you want to make sure that you're speaking to the right form, and that would help you to see a copy of that form that you're speaking to. We, as part of DCA MLP, we actually have some capacity letter do's and don'ts and a template capacity letter that has some suggestions about how to write that. And a big piece of that is to constrain what you say. And you can make it a time-bound assessment. Like, I think for the next 6 months, this is true, right? If you're not sure. And then the other thing is, I want to just be careful to say that some health systems, including some divisions in this one, don't permit their healthcare providers to write capacity assessments. And so lean on, and we should talk through more the implications of those policies, because an effect of those policies could be that if a caregiver can't get an assessment in their health system, they may have to go out of network, right? The form that an attorney created for their mom says it's not valid until they get a physician's assessment, right? So it's not valid until they get a physician's assessment. So if they can't find anyone they're already seeing to do that, they may have to go out of network, out of pocket to do that. Like some people will be able to do that and some people won't. And so if patients and caregivers who are working in good faith can't use the tools we're encouraging them to use, that is another structural driver toward conservatorship, right? Because my sense is that most health systems aren't saying you can't fill out the CAP deck for conservatorship, but they seem to be real nervous about you filling out a form for a POA. And that to me seems like, is that the direction we want to go? So it's not to say that the risks aren't unfounded, the concerns aren't unfounded, but I do think we have to be, if that's a choice a health system is going to make, we should be clear that we may be creating a conservatorship problem. So it's just a different kind of risk. Yeah.
Can you think of any circumstances where someone would still need a conservatorship even if they've done advanced financial and development planning?
Yeah, unfortunately. So if the person who is named is exploiting them is a common reason that you would initiate conservatorship, to essentially remove the agent and have a conservator step in. If someone, abuse cases are pretty clear. Or if I also tend to think some of those can be the result of just like bad planning, where the caregiver wasn't quite clear. And unfortunately, it happens all the time. People will plan with an attorney and then never talk to their agent about it. And the agent is like not on the same page and not prepared for the role. And so we need to do a better job of that. That's like another project I'm working on. But that is something we can do is help people. No one trains caregivers, right, in the role, and especially no one trains caregivers in their legal role. And I think there are a lot of well-intentioned caregivers who overstep or misstep, not because they're malicious, but because they really didn't know. And we can help prevent those cases, right? Like, let's just at least help those people from accidentally creating elder abuse. Yeah.
Can you try to see if the DPOA of healthcare decision making and finances are the same? Because I actually have a situation where a patient has two children and one is designated as one and the other one's designated as the other. And it sometimes seems a little bit tricky to navigate if they're not on the same page and you're looking at how to use finances to fund long-term care.
Totally.
So I'm just curious if the preference is to have one person be both things, or
it's a great question. So that's part of the counseling and the assessment of a patient's social network is, and then patient's preference. So giving one person all the authority can really help streamline and may be necessary. It's also giving one person a lot of authority. And so there may be reasons that a patient will want to divvy up the authority, or that might make sense for a family to have one person kind of manage finances. It does require often that they are able to work in tandem. So some of the videos we're actually adding to Clarity is around family conflict and how to think about managing those issues. But I do think a lot of this comes down to people are not prepared for these roles. And we're asking a lot of them. And then for these high-risk patients, they're making these decisions in fairly high risk situations, like you're going to get evicted, or you're going to get your power shut off, or like there's not a lot of room for errors, whereas higher income people can kind of throw money at problems. There's just less room for error for some of these high-risk people. So yeah, that's a lot of what legal counseling is just like, what would be the best way to structure your decision-making architecture for your family? Like, what makes sense there?
Let me just final, and these are the last questions.
I know, remember, yeah.
But just there's a couple statements here on Zoom, or this Elizabeth Sutherland says, for financial DPOA, I do verify and get the paperwork since I do capacity evaluations. So she was saying what you did. And also you have another invitation to do another talk. So Salome Locks, who says, I feel that this presentation is needed and would be well received in Marin. I am affiliated with the Marin County Commission on Aging. This knowledge needs to be broadcast everywhere. Please advise. So I'll give you and then the last question is around Nuisha asked, can older refugee adult patients access the same resources?
Yeah. So the planning tools, so basic planning tools like POAs are don't matter where you're from, and public benefits. So California is one of the more generous states, even though undocumented people with people with refugees, if they have actual refugee status, should be able to access a lot of benefits. It's really the undocumented folks that encounter barriers, but we're expanding Medicaid for people without who are undocumented, and then a lot of public benefits can still be available. I was really excited to see actually that our area agency on aging in San Francisco just put out a whole kind of public campaign around how immigrants without status can still access benefits, because I think there's a perception that they can't, but in reality, there's a lot that can still be done. But the planning tools are the same legal tools, really. There just may be other additional kind of quality of life considerations. And actually, a colleague of mine was doing advanced care planning in the event that someone is deported. So not in the event of incapacity, but like who is going to manage the family if this person is deported. So, but it's the same tools, but different sets of considerations about what it is that we're planning for that might matter to people.
Yeah, fantastic. Well, thank you so much. Obviously, a lot of discussion here. Thank you. All right, thanks everybody.
Thanks, Sam.